But yeah, was a tricky title. This is a massive subject. I'm glad you found it challenging too. I thought actually I might just start. John Updike, I don't know how many of you have read his books. They're fabulous. But he also had terrible psoriasis from the age of 6. And it changed his life. It's in fact why he was a writer, because he he didn't want to show his skin. And he talks and writes very movingly about the stigma and effect on his mood. And of course, mental health problems are a comorbidity. But actually, he was otherwise very fit. And he made this comment that people with psoriasis are actually in very good health. And I wonder whether we feel that that's still true today. I mean, epidemiologically, most people with psoriasis have no more or less comorbid a burden than the general population. But nevertheless, there is a burden of comorbid disease that is important and is definitely more prevalent in those with more severe skin disease. This is a lovely study in 2006, just illustrated myocardial infarction. I don't think there is any doubt that there's an association between cardiovascular disease and psoriasis. It's the causal relationship that's in question. But we do know also it contributes to the cumulative life course impairment in people with the disease. So it's important, and therefore there's an opportunity to improve outcomes with biomarkers. So I'm going to talk about some general principles where we are now and looking forward, because actually in reality, apart from clinical biomarkers, which I'll talk about briefly, there aren't any really good biomarkers that accurately predict risk of comorbid disease. So the important principles, one is, where is the opportunity? There are a lot of comorbidities. Which do we target? You asked earlier on, Johan, where should we look? But also we might want to think about which are the most important ones to focus our attention. But firstly, better diagnostic biomarkers would help the whole field. For example, in psoriatic arthritis, the diagnosis of that is very difficult. If you're developing a biomarker, a prognostic biomarker, and the outcome is so difficult to measure, that's challenging. But as also Sapphire has said, the opportunity to intervene early and potentially prevent and modify that disease trajectory, although that is still to be proven. As Christian said, the term biomarker is, I like this FDA definition because it's very, very inclusive, but it's important to remember that if your biomarker is mechanistically related between your exposure and outcome, it's going to be a better biomarker than that's further away from the causal pathway. And that's why the effort and discovery around molecular mechanisms is so important. The other thing just to sort out is terminology. It's certainly an area that I sometimes get confused, but a comorbidity is a distinct entity related to your index disease, psoriasis here, whereas multimorbidity is a coexistence of any two or more chronic conditions. And of course, multimorbidity is very common in the general population, and this is also important when you're thinking about biomarkers in the context of psoriasis. So this study took around 4 million patients in the UK health records and defined multimorbidity as ever occurrence of two or more conditions over the lifetime or period of documentation in the same individual. And that's important when you're thinking about comorbidity development and therefore biomarker development, because of course the biological mechanisms driving that comorbidity may occur decades before the disease manifests. So the point I wanted to make here was that there's a lot of prevalent comorbidities that are in psoriasis that are obviously very common in the general population. Whereas, and in the same paper, if you look at those morbidities that occurred more often than expected by chance, those nodes relate, the blobs relate to the condition and the size proportional to the prevalence, and the thickness of the lines, the importance of the correlate. So I think this is a sort of principle that's important when you're thinking about your biomarker. Where are you going to deploy it? What's the target population? So where are we now? Well, as Christian's mentioned, weight is a perfect clinical biomarker. I mean, it's incredibly predictive. possibly difficult to address. But it is a very strong risk factor, not only for development of psoriasis, but also for the progression to psoriatic arthritis and, of course, cardiometabolic disease. And these biomarkers are integrated into routine clinical care already, with risk thresholds for intervention in the general population. So the SCVD is used in the States. We have the Q-risk in the UK. And there has been an argument to say these need to be validated in the psoriasis population, but and one such validation study in the CPRD suggests that actually it doesn't perform badly, particularly if you're just looking at psoriasis. The AUC there is 0.815 with a very high negative predictive value, although the problem is that the positive predictive value is low, and as illustrated by Alison earlier on, of course, cardiovascular disease outcomes are higher than they're there, but they're not that common, and that's probably we need very precise biomarkers to be strongly predictive. And in fact, we scoped the research landscape, and although this is a couple of years old now, it hasn't substantially changed in terms of the principles, in that there's a whole mess of biomarkers out there, but most of them are in the discovery phase and haven't been validated. And we picked out some candidates, and the detail probably isn't important, except to say that it's interesting that some of them seem to go across multiple groups of what you might call disease progression, so severity, arthritis, and diabetes. But these are the challenges in this area generally. So on a positive note, there are these very large, ongoing, collaborative, data-driven research efforts to identify clinically useful biomarkers. I'm just going to talk about a few things that I'm sort of involved in with our group. So first of all, if you think about comorbidity, it does occur in the more severe population. And so could we better identify the more severe population? That would be important for trials if you were going to intervene early and see if you could progress. And it also might be important for developing biomarkers. And so looking across multiple biobanks, there's evidence that individuals with a higher genetic liability for psoriasis are also more likely to develop severe disease. So as Satvir showed, this has been integrated and looked at across 4 population-based biobanks, so that the next stage will be, if you can integrate these, do you get a better prediction of more severe disease? And also, how does that relate then to subsequent development of comorbidities? It may not be any better as an integrated multimodal biomarker. Psoriatic arthritis, I think this is something that's really worth going after, but it's challenging. This review is quite nice because it does summarize essentially. It's a bit old, but it does summarize more or less the state of play, in that we know that there are clinical risk predictors, subphenotypes of psoriasis, a family history, more severe disease, obesity, and then there are more serum biomarkers published now, but essentially they're all still at the discovery phase, not in clinical practice. But in reference to the outcome and this idea of subclinical musculoskeletal inflammation, there's been a change in the terminology to try and make this more precise, and also then when you're sorting out all of the different cohorts which Hippocrates are trying to do and aligning and curating them, you can then determine your cohort, how the PSA was diagnosed, was there a prodrome, and try and get some commonality in order to really interrogate then the underlying, the collected molecular data. And as part of this, there's this massive effort across Europe to collect 25,000 patients with psoriasis who may then develop to try and pick up instant PSA associated then with collecting DNA from this cohort as well. So it's a potentially really powerful tool. And we'll pick up, Nick, as you said, these patient-reported outcomes of change in symptoms and patient-reported outcomes over repeated times. And finally, cardiovascular disease. So this is, I'm nearly finished, but there is this prevailing view that psoriasis is a systemic disease, and that is the inflammation that's driving the cardiovascular risk. But as Christian alluded to, of course, there are lots of confounding factors that make unpicking this relationship very, very challenging, because the risk factors that we see in the psoriasis population are also risk factors for cardiovascular disease. And so, as you will all be familiar, this technique, Mendelian randomization, where essentially the genetics are used as an instrumental variable that's not affected by that confounding those confounding factors, to try and get around this problem. And so it does have its own challenges, Mendelian randomization, and Sarah is a much better expert than I am. But nevertheless, it can help to try and unpick the causal direction of effect. And Ravi, who's just finished doing his PhD with our group, has looked at this very systematically to try and unpick this relationship. And this is just about to be published. But in short, what he found is that the genetic predictors of both coronary artery disease and stroke increase risk of psoriasis, but not the other way around. And in fact, those genetic predictors are those shared by coronary artery disease and stroke, suggesting that the biological pathways influencing cardiovascular disease contribute to psoriasis risk. And in the context of biomarkers, it may well be that we've been looking in the wrong place for those biomarkers. So just to summarize, we do have risk prediction tools that we're already using in the general population. Should we be using them, and could we be using them just more systematically in our psoriasis population? I do think that we need to understand mechanisms first and then develop the biomarker afterwards. Otherwise, you're fishing in a looking for a needle in a haystack. And with that in mind, perhaps we need to think about better stratifying the population at risk for those mechanistic studies. But, I'm optimistic. The opportunity is great. And just to say thank you to everyone I work with. Thank you.